Welcome to Unit 6, Musculoskeletal and Orthopedic Care. In this unit, we'll explore disorders that affect bones, joints, muscles, and connective tissues. We'll focus on inflammatory conditions like gout and rheumatoid arthritis, degenerative disorders such as osteoarthritis, metabolic bone conditions like osteoporosis, fracture management, traction care, wound healing, and priority neurovascular assessments. As we move through this unit, I want you to think in terms of safety, early complication recognition, and priority nursing interventions. Many musculoskeletal conditions can quickly become limb-threatening or life-threatening if not identified early, especially compartment syndrome, fat embolism, infection, and electrolyte disturbances. We will also review dosage calculations relevant to orthopedic and IV therapies, so be prepared to apply both clinical judgment and math accuracy. Let's get started.
Now, let's move into inflammatory and metabolic bone disorders. First, gout pathophysiology. Gout develops due to hyperuricemia, elevated uric acid levels in the blood. When uric acid accumulates, it forms monosodium urate crystals that deposit inside joints. These sharp crystals trigger an intense acute inflammatory response, leading to sudden, severe pain, redness, swelling, and warmth. The great toe is the most commonly affected joint. For exams, remember, sudden severe joint pain in the great toe equals acute gout attack. Next, gout flare reduction. Long-term management focuses on reducing uric acid levels. Hydration increases renal excretion of uric acid. Patients should avoid alcohol, especially beer, and high purine foods, such as red meat, organ meats, and shellfish. Lifestyle modification plays a major role in preventing recurrence. Now let's discuss osteomalacia. Osteomalacia is caused by vitamin D deficiency, which impairs calcium absorption. Without adequate vitamin D, bones cannot properly mineralize, leading to soft, weak bones. Treatment requires long-term vitamin D and calcium supplementation because bone remodeling is slow and may take months to improve. So overall, inflammatory disorders like gout involve acute immune responses, while metabolic disorders like osteomalacia involve impaired bone mineralization.
Now let's move into arthritis and chronic joint disorders. First, salicylate toxicity. Salicylates are commonly found in medications like aspirin. Aspirin is widely used for pain relief, inflammation, and cardiovascular protection, but in high doses it can become toxic. The earliest sign of salicylate toxicity is tinnitus, ringing in the ears. This occurs before metabolic acidosis develops and serves as an early warning sign of rising salicylate levels. In early toxicity, patients may hyperventilate, leading to respiratory alkalosis. As toxicity worsens, metabolic acidosis can develop. For exam questions, if a patient taking aspirin reports ringing in the ears, think early salicylate toxicity and intervene promptly. Next, rheumatoid arthritis management. Rheumatoid arthritis is a chronic inflammatory autoimmune disorder that affects joints symmetrically. Because patients often experience joint deformities, reduced grip strength, and limited dexterity, medication adherence can become challenging. Using adaptive devices, such as easy open containers, improves compliance and supports independence. Now, let's compare osteoarthritis and rheumatoid arthritis. Osteoarthritis is degenerative. It results from cartilage wear and tear. It is typically asymmetric and causes brief morning stiffness that improves with movement. Rheumatoid arthritis is inflammatory, autoimmune, and symmetric. It causes prolonged morning stiffness, often lasting more than 30 to 60 minutes. For exams, remember, degenerative and brief stiffness. Think osteoarthritis. Inflammatory and prolonged stiffness. Think rheumatoid arthritis.
Now let's move into bone infection and neuromuscular disorders. First, osteomyelitis risk. Osteomyelitis is a serious bone infection. Open wounds, pressure ulcers, or exposed fractures allow bacteria to enter the bone. Once bacteria reach the bone tissue, the infection can spread quickly and may require prolonged IV antibiotics or even surgical debridement. For exams, remember, Open wound plus bone involvement equals high risk for osteomyelitis. Next, sciatica. Sciatica causes radiating pain that travels from the lower back down the leg. This happens because the sciatic nerve is compressed, often due to a herniated disc or spinal stenosis pressing on the nerve roots. The key word is radiating pain. That should make you think nerve compression. Now, carpal tunnel syndrome and crepitus. Carpal tunnel syndrome results from compression of the median nerve within the carpal tunnel of the wrist. Patients commonly report numbness or tingling in the thumb, index, and middle fingers. Crepitus, on the other hand, is a grating or crackling sensation caused by rough cartilage surfaces rubbing together. It is commonly seen in degenerative joint disease, such as osteoarthritis. So on this slide, think infection risk, nerve compression symptoms, and degenerative joint changes.
Now let's discuss osteoporosis and bone health. First, alendronate and fracture prevention. Alendronate, also known as Fosamax, is a bisphosphonate. It works by inhibiting osteoclasts, the cells responsible for bone resorption. By slowing bone breakdown, bone density increases, which significantly reduces fracture risk in patients with osteoporosis. For exam questions, remember, osteoclast inhibition equals decreased bone resorption. Next, high-risk groups and nutrition. Postmenopausal women are at highest risk for osteoporosis because decreased estrogen accelerates bone loss. Estrogen normally protects bone density, so when levels drop, bone resorption increases. Calcium builds bone structure, while vitamin D allows calcium absorption from the intestines. Both are essential for maintaining bone health. Finally, exercise and fall prevention. Weight-bearing exercise stimulates osteoblast activity, the cells responsible for bone formation. Activities like walking or resistance training strengthen bone over time. Fall prevention is equally important. Removing loose rugs, improving lighting, and addressing vision problems reduce fracture risk. Remember, in osteoporosis patients, even minor falls can lead to serious fractures, such as hip or compression fractures. So, when thinking about osteoporosis, focus on medication, nutrition, exercise, and fall safety.
Now let's discuss fractures and cast safety. This is high-priority nursing content. First, priority assessments. With long bone fractures, neurovascular checks are essential. Always assess pulse, color, temperature, capillary refill, movement, and sensation. These assessments help detect ischemia early. If circulation is compromised, tissue damage can occur quickly. Open fractures require urgent attention because exposed bone significantly increases infection risk. Next, limb elevation and hematoma. Elevating the affected limb helps promote venous return and reduce swelling. However, if a hematoma develops and the pulse becomes weak, this may indicate vessel compression. That requires immediate intervention. Now, compartment syndrome. This is critical. The earliest sign of compartment syndrome is severe, unrelieved pain that is disproportionate to the injury. This pain is caused by increased pressure within the muscle compartment, which compromises blood flow. If pulses are absent, this is a late and dangerous sign. Notify the provider immediately. Untreated compartment syndrome can result in permanent nerve damage or limb loss. For exams, remember, severe pain out of proportion equals early compartment syndrome. Absent pulse equals emergency.
Now let's move into traction and immobility care. First, Buck's traction monitoring. Traction is used to stabilize fractures and reduce muscle spasms, but it can impair circulation and nerve function. Because of this, frequent neurovascular checks are essential. Always assess pulse, color, temperature, movement, and sensation. Early detection prevents ischemia and permanent nerve damage. Next, deep vein thrombosis and pneumonia prevention. Immobility increases the risk of blood clots and respiratory complications. Encourage ankle pumps to promote venous return and reduce the risk of deep vein thrombosis. Incentive spirometry should be used regularly to prevent atelectasis and pneumonia. For exams, remember, immobility equals DVT and pneumonia risk. Now, Fat embolism and pressure injury. Fat embolism is a serious complication that can occur after long bone fractures. Early signs include respiratory distress, tachycardia, confusion, and petechiae. If a patient with a recent fracture suddenly becomes short of breath, think fat embolism. Finally, reposition patients every 2 hours. This restores capillary perfusion, prevents pressure injuries, and reduces the risk of tissue necrosis. So, on this slide, think traction safety, immobility complications, and early emergency recognition.
Now, let's review wound care and discharge planning. First, signs of wound infection. Foul-smelling drainage is a key indicator of infection. Increased redness, swelling, and warmth around the wound suggest inflammation. Persistent pain or tenderness that does not improve may also signal infection. If you see delayed healing or wound breakdown, that requires prompt evaluation. For surgical site infections, symptoms often develop 3 to 7 days after surgery. Watch for discharge from the wound, noticeable odor, redness extending beyond the incision, warmth, fever, chills, or sweating. Early recognition prevents systemic complications. Now, let's discuss amputation discharge requirements. Before discharge, the patient must demonstrate safe use of assistive devices. Proper training on walkers, crutches, or prosthetics is essential. Patient confidence and mobility reduce fall risk and improve recovery outcomes. Discharge planning is multidisciplinary, involving nursing, physical therapy, and sometimes occupational therapy. So, on this slide, think infection recognition, patient education, and safe transition home.
To wrap up, this final slide provides a brief review of common dosage calculations. I encourage you to work through each question independently to strengthen both your accuracy and your confidence in medication math.
Thank you for reviewing Unit 6, Musculoskeletal and Orthopedic Care. As you continue studying, focus on priority assessments, early complication recognition, and safe nursing interventions. Pay special attention to neurovascular checks, compartment syndrome, infection signs, immobility risks, and medication management. Make sure to review the Need to Know document and practice dosage calculations before your exam. If you have questions, reach out. I'm here to support you. I'll see you in the next unit.